All right. Well, good evening. Thank you all for joining here this evening. My name is Christy Sluzarzik, and I have the pleasure of introducing Dr. Salil Khandwala. So thank you guys for attending here today. I'm going to share my screen here in just one moment, and then we will get started. Dr. Khandwala, thank you so much for putting this on for us here this evening.
Thank you very much. Hello and good evening, ladies and gentlemen. We'll be talking on one of our series of webinars on female pelvic health. And today, the topic is medically called fecal incontinence, or now as we call it, accidental bowel leakage. It is time to leave it behind us. So let's move forward. Let's see what can be done and what this condition is. Let's see how I can advance these slides. Do you advance it or can I? All right. So it is a condition that is associated with accidental leakage of stools, whether solid or liquid. It may start off with gas leakage, and then it could advance to liquid leakage and sometimes stool leakage. And many a times women are not even aware that this condition is happening. Yes, it also happens in men, but more frequently in women, as we'll go to the next slide. 1 in 4 women over the age of 65 years are affected by bowel leakage. So it's a very common condition. It's an extremely distressing condition because you never know when it could happen. And when it happens, it is so humiliating when you have bowel leakage, much more than urine leakage. Mind you, in the past, we thought, or even today, we feel that urine leakage is significantly more common. Well, bowel leakage may be as common. It is just that we don't know. Women and even men don't come forth with it because they're so much concerned, scared, afraid, and traumatized by what is happening. Even young women after just 1 child can potentially get bowel leakage. Next slide, please. 50% of residents in nursing homes have bowel leakage, and that itself, because of stool soilage of the vaginal opening and the perineum, can cause bladder infections. Very common reason why. I mean, how can I mingle with others? And if I feel that, oh my God, did I lose stools? Will I be smelling to everybody around me? I would shy away, isolate myself, and that itself can cause issues such as depression and social isolationism. Next slide, please. Is there a way for me to control the slides, or let's see? Maybe not. So it occurs 8 times more often in women than in men. So you see how it's very common. There's a reason, some anatomical differences between women and men that predispose women. And of course, childbearing is one of the main factors that is associated or causes bowel leakage. So as I said, just reiterating again, it's not exclusively a disease state or a condition that happens in the elderly. It could happen right from the get-go. A young woman has a child and she can get this issue. But that doesn't mean that you have to just live with it. Next slide, please. Most cases, if not all, can be corrected or significantly improved to the patient's satisfaction. This bowel leakage completely takes over and affects the quality of life of a woman. But this condition can be corrected satisfactorily, that now she's satisfied with how things are going. Most of these treatments can be carried out either in the office or an outpatient setting. No hospitalization is required. Next, please. Pads, never. Do not ever wear pads. All it does is weakens the pelvic floor, worsens bowel leakage. Next, please. As I mentioned, social impact, terrible. Not only is it embarrassing, it's debilitating. It causes local hygiene problems, causes irritation at the anal opening, can predispose to bladder infections, and just that perpetual odor results in tremendous depression and isolationism. But despite all that, nobody wants to talk about it. I mean, I would ask you right now, if you were an open audience, why? Why would you not talk about a condition that is so debilitating, so crippling, so much bothersome, so much it affects your quality of life, and can be corrected with great results? Why would you not talk about that? Next slide. So why is it still the elephant in the room? Why does bowel leakage happen? So let's go to that. Why does it happen? Let's find out. So as you can see here, I don't know if you can see my cursor. Let me see if I can take over. Request remote control. What it is? Can you see my cursor now? Click to start remote control on the share screen. I don't know if you can. Are you able to see my cursor at all? No.
I don't see your cursor, Dr. Kandwala, but you do have control now of the slides.
I don't know I can. Okay, so basically what you're looking at is that image of the bowel. On the left side is the, I said it's A, that's where the cecum is, and it goes up, and the horizontal one is the transverse colon and comes down to the right side and opens at the rectum or the anal canal. Next slide, please. Oh, I have control, right? So here, as you can see, it's a magnified image of the lower part of the rectum, and around that rectum, let me see if I can, there's a way for me to show my cursor.
Let me give you back, let me see if I can give you. Here we go.
Viewing. Can you see my cursor or no? I can't, right? On the screen? Well, because I didn't start the slides, that's probably why. Okay, so around this rectum, where unless you can show it, around the rectum, you see these blue marks. Around that, the muscle, the sphincter muscle, yeah, you can. Good. The sphincter muscle is what Christy is showing you, and that is the sphincter muscle that controls that rectum. Can you imagine, you know how good that sphincter muscle is? Just think about it. The entire bowel is moving its contents, the stools, downwards. So it's like propelling it down and down and down. And the only thing left, the only gate left is that sphincter. If that sphincter were to be weak, it's going to come out. So this sphincter is so powerful and so good that it prevents the leakage of stools and lets the stools remain there until the time is correct to go to the bathroom. Next slide. Oh, maybe I have. So what you can see, it's called the puborectalis in pink. So that muscle right there holds that rectum forward and therefore maintains continence. So there's this muscle at the end of the bowel that is so important to maintain continence, prevent leakage. Next, please. However, if there is a weakness of those muscles and it gets torn, broken down, weak, then you get leakage. Next slide, please. So why does it happen? So that is the mechanism. The weakness of the muscles is one of the mechanisms why you get bowel leakage. Now let us see what could potentially be the causes. Next slide. And lo and behold, number one cause is childbirth. We were just talking about it. Someone's about to have a baby, and hopefully this won't happen to her, but this is a risk factor. As you can see, the yellow depicted is the pelvic muscle. The baby's coming down and it stretches that muscle significantly. Look, as it goes down further onto the lower part of the slide on the left side, you can see how it's stretched, and on the right side, it's like completely stretched out. But the beauty is that even if the muscle gets stretched out, that doesn't mean that it'll fail. It regains its composure after the birth of the baby. But in some cases, next slide, please. Some cases, the childbirth results in the tearing. As you can see, the white muscle on the side of the baby's head, there's a tearing of that muscle, and that tearing of that muscle may not regain its complete tone, and that could predispose to bowel leakage and also a subsequent topic, prolapse and urine leakage. Next slide, please. Hemorrhoids also sometimes, excision of hemorrhoids. If someone was asking me earlier, excision of hemorrhoids can also cause some damage to the sphincter and predispose to bowel leakage. Next slide. And so also constipation. Do I have control? Yeah, and Constipation, we'll talk about in a second, but when there is constipation and stool gets backed up, as you can see in that rectum, that puts tremendous pressure on the sphincter muscle. So the irony is that constipation can result actually in bowel leakage. So when you look, and the other conditions such as bowel hurry, when someone has Crohn's ulcerative colitis and the bowel is hurrying fast, or you know what, if you and I get food poisoning, then the same thing could happen. And that's a totally different reason for bowel leakage. So there are different types. One is the most bothersome, which is passive. I don't even know, and my stools are sitting in my underwear. I didn't even realize it. I'm just dropping stool pellets behind me. Urgency is a more common type where I feel I've got to get to the bathroom, and before I can get there, stools are coming out. And the third, which is a massive nuisance, is after you have a bowel movement and you think you are done, and then you're wiping and keep wiping, and it just does not get clean. The sphincter just does not shut down. So these are the three common types of how you get bowel leakage. What do we find on examination? So one thing we tell the patients is do a pictogram. Tell us, what is your stool consistency? Is it type 1, absolutely constipated and pellets, or is it type 7, mush? We want to be type 4, proper sausage-like stool that comes out, falls in the toilet bowl, and does not break down. That is the stool consistency we need. Anything else, if it's too dry, too much constipated, too slow, and that itself can be a problem. Or of course, if it's too loose, it'll just come running out. So that's one. Then on examination, we look at, does she have any associated findings? Like in this case, you can see the rectum is bulging forward towards the vagina, and that is the rectocele. If Christy could just point on that rectocele coming up there, right there, that's a rectocele coming up, and that could be holding the stools and weakening that muscle below it. Then we look at, does the patient have rectal prolapse? So she may in fact have a rectum turned inside out and coming out. That could be one of the factors. And lastly, what we call an absolutely weakened perineum. You can see between the vagina and the rectum, there is absolutely no muscle. So this muscle could have got torn during childbirth, and where you can see those little stars, little asterisks, that is where the muscle is. There's nothing in front between the rectum and the vagina. It's like as though it's like almost no separation between the vagina and the rectum. We do a test called anorectal manometry then. So once we do the examination, this anorectal manometry assesses, it's like the blood pressure test. You know, someone says, I have high blood pressure. We check the blood pressure. So this is like the blood pressure machine that shows us how good is that rectal muscle. Is it weak or is it strong? And then we do the recording of that and get an idea as to how good it is. And we look at what are the pressures and is the patient able to expel the balloon. Then we do an ultrasound. So we have a 3D ultrasound, which looks at, and as you can see, the right side, like a block diagram of the sphincter. What you're looking at is that white muscle. You can see that white ring all around, and that white ring is completely intact. And that is a normal intact sphincter. However, if there is a tear and a break, you can see that white is where the arrow is, that it ends there. And in front, there is no white. It's all black. So the front is the top. So Christy, can you mark that top? Go from 9 o'clock through 12 to 3 o'clock. So that front part, as you can see right in front at the top. Yeah, go to the right. And yep, that whole area, there is no sphincter muscle. That's torn. The sphincter is only where she is showing you right now. So when there is instead of the rectal sphincter being intact, if it's torn open, that may compromise the ability for it to squeeze and prevent leakage of stools. Well, now you know, it's very common, very distressing, can cause other problems such as bladder infections. And obviously, if one is having stool leakage, she clearly does not want to engage in intercourse, with her partner. Doesn't matter how many years they've been married. So it affects the quality of life. You know how we can make the diagnosis so easily in the office with some simple tests that take about 10 to 15 minutes to do. And then we come on to the treatment. So the treatment, as always, you've got to treat what is the problem underlying. Does she have constipation? Does she have the rectal protruding out? Then it is to educate them. What is, just like what I showed you, how does the sphincter work? Improving the stool consistency. You do not want that mush stools. You want the stools to be well formed. If they're well formed, that's all she may need. Okay sphincter, not very good sphincter, but okay sphincter in the presence of loose stools can allow that stools to leak out. But an okay sphincter in the presence of well-formed stools will not let it leak out. That is why, many women may have some compromise of the sphincter, but if the stools are well-formed, that may be all she may need. And then, of course, to prevent the leakage, anal hygiene and scheduled toileting. Do not just wait and wait. When you have the sensation to go, make your way towards the restroom. Avoid certain substances that can increase bowel motility, and then certain medications. Now, if the stools, as I showed you, are very mush, you can make them proper in consistency, provided there is no gastrointestinal problem. So had a colonoscopy, that's fine. Nothing's wrong with the colon. Then we can put you on a medication that can help improve the consistency of the stools. And once the consistency improves, then the stool incontinence may well stop. You won't have the leakage. So loperamide is like Imodium, can be used, provided a doctor tells you to do so. Pelvic floor therapy. Do not discount the value of exercising the correct muscles. It's not all about, I've still not come to medications and surgery. We're still talking about simple remedies that can be done. Pelvic floor therapy, strengthening those muscles of the anal sphincter, making them again tighter and more involved, with or without the assistance of a physical therapist can help. So we have a physical therapist at the office who works with our patients and helps them get these muscles to get improved and stronger. And that's what this does. It stimulates those muscles and makes them stronger. And then we come to surgery. So I have not even talked about surgery until now. So key things, remember, dietarily improving the stool consistency, maybe medications to improve stool consistency, working on the pelvic floor muscles, strengthening them. When one has done all that, then we get to the next two steps. The surgical procedure is now the sphincter muscle is torn, as you can see on the left side of the screen. And now on the right side, you can see that now the muscle is coming together. You see how there's an overlap and the muscle is stitched together. It's all done by making an incision in between the vagina and the rectum, as you can see in the middle of the screen. It's an outpatient procedure. It takes about a half an hour to an hour to perform. And we're trying to get the muscle together so the area looks a little bruised. And I tell my patients, apply ice like never before. And once they apply ice, it can make a huge difference in postoperative pain. And then depending upon the integrity of the nerves, the success would vary, but at least it gives a good fighting chance for a sphincter which is completely broken and open. As you can see here, the top slide shows a sphincter that's broken. The lower slide shows how it's brought together. So it's done at the anal opening, as I mentioned, doesn't take that long to perform, but needs an appropriate functioning nerve. The issue sometimes with that anal sphincter repair that I just discussed is that the long-term success has not been documented to be very high. And it causes some problems because there's some discomfort and pain. So if I was exclusively going to manage that, then I would do the Interstim rather than the anal sphincter repair. On the other hand, if there was some prolapse surgery happening along with, then repairing the sphincter makes sense. What is Interstim? So Interstim is a nerve stimulator that is placed in the buttocks, and that has a tiny lead that influences that little nerve that's coming out. So if you show that S3 nerve coming out also on the left side of that screen, and you can see that nerve coming out, and that is the nerve that affects the bladder and the bowel. And by stimulating it, it regulates that sphincter of the rectum and also the storage of the rectum. So both, not only is the sphincter made stronger, but the storage is allowed to improve. And that is how it helps with bowel leakage. So good news is that if someone has urine leakage and bowel leakage, it could help both at the same time. It is the S3 nerve. It has been approved by the FDA. It's been around now for several years, approved by the FDA for management of bowel leakage. Success is high. then minimal to no complications. It's a tiny incision in the buttocks. It takes me sometimes less than half an hour to do this procedure. It's done with the patient prone, laying on her belly under sedation. It is done within an hour. The patient is home, back to all activities. That's the beauty of doing this procedure. So it's very quick in an outpatient setting rather than any admission to the hospital. Rare complications. 70% of patients will notice at least a 50% improvement in the symptoms at 12 months. What that means is if I was having 4 bowel leakage episodes, then I'm down to maybe 1 or 2 or less than 2, and I'm within that 70% of those women. So the remaining may not be as high, but at least they'll see some improvement. And hopefully with the dietary modifications, going to the bathroom appropriately, doing the muscle exercises, improving the consistency of the stools, and doing this could give up the overall good quality of life results. So bottom line, to conclude, let me tell you this. This is a huge problem. It's a huge problem, and it is an exponentially growing problem, especially as elderly women and human men also are living longer and living a high quality life, walking around. They're not bed bound anymore. We're talking right now in the 80s, soon it'll be 90s and in the hundreds. So it's a huge problem. And it is, as I said, not only the problem of the elderly. It can happen at any age. Not difficult to diagnose, straightforward diagnosis done in the office, and the treatment is very straightforward. The patient has to get involved. She's got to make sure that she does the right things, avoid certain bad things, eats correctly, probiotics, improves the bioflora of the gut, improves the stool consistency, keeps working on the sphincter muscle, and then what else we can do for them with the procedures I mentioned. So repairing the torn sphincter or the interstim and maintaining proper hygiene can really significantly improve the quality of life, that now she does not have to worry that what's going to happen if I eat something and, oh my God, I've got to rush to the bathroom when I eat something and I have to leave everything as is and make a mad dash. Well, with these things, that won't happen. That doesn't mean you can go to the bathroom tomorrow and wait like the whole day. You can go, but it won't be a mad rush. So these are the different options available to us and to offer to our patients. And all these can be done in an outpatient setting. So that is how much this management has changed. So why then, knowing this, what I just told you, why would you just wear pads, right? It makes no sense. Why would a woman just wear pads? And why would she just bear with it? Those days of bearing with things are gone. It's time to leave it behind you. It was happening from the behind of you. Now leave it behind you. Don't deal with it. Take care of it. Enjoy life. Live your life. It doesn't matter how old you are. Live the life that you want to live and lead, and stop suffering in silence. Thank you.
Awesome. Thanks, Dr. Khandwala. I had a patient recently that was one of our patients that we worked with, and she was driving around with a porta potty in her car because it would come out of nowhere for 7 years with a toilet in her car. I mean, it's crazy. And now she's back to, living life, going to her grandkids' events, and she doesn't have to bring the porta potty anymore.
Yeah.
So I mean, it's amazing.
It is so sad that women have to deal with this, and they deal with this, and the reason is not because they're embarrassed about it. The reason is because they're not aware, and that's exactly why we are doing these seminars on women's pelvic health. These are conditions that are very common, whether you talk about urine leakage, bowel leakage, vaginal pain, pain during intercourse, pelvic prolapse. These are very common problems, very common, but there are solutions that are very effective and safe and almost devoid of complications. Can be done in the office or maybe an outpatient center, and you are done. It's taken care of.
So, Dr. Khandwala, we actually were able to get a few questions ahead of time, and I know there's some that have come through. So I'm going to start with our submitted questions, if that's okay with you.
Sure.
Okay. So the first question is, again, is this a problem of only elderly? And does being overweight have any cause on the bowel leakage?
So first, I think you got the answer already. I know you were, I'm sure you're listening, but clearly you're right. Elderly women may be more likely, but you know what I feel is that they have been waiting so long, and then it's the last hair on the camel's back. I'm fed up of dealing with this. It may have started bothering me about 5 or 7 years ago, but now I'm so done. I want to get this done, taken care of. And that's why we see women come at a later age than earlier on, because earlier on they say, oh my God, what has happened to me? And they're sort of in a shock and they have no idea what to do about it. If they knew this seminar and they'd heard and they're aware of this, nobody wants to wait. Overweight, to some extent, yes. Anytime there's overweight, there's always a concern of pressure being on the bowel. And sometimes overweight could be associated with low thyroid that can cause constipation, and that can also cause this problem. So yes, not always, but yes, overweight obviously would influence.
Another one came in and said, I only have bowel leakage if I have bowel, hurry, and loose stools. What should I do?
Yeah, just like what we talked about. That's a very good point. There's no point going and repairing the sphincter or doing the interstim. Here, where we need to do is figure out what is going on. She may have a food allergy, and that's what she needs to take care of. And then once they realize that this is an allergy to a food, and she gets rid of the food or figures out how to manage that allergy, and suddenly her stools are well formed. So it's so important to understand. It's a handshake, I tell my patients. I can't do this alone without my patient's support and assistance. She needs to make sure that she's eating correctly. She is doing everything she can to optimize her stools. And once she does that, then we can go to the next step. So that is key. And then if she's done everything and she says, I don't have any allergy, I checked everything is good, my colonoscopy is good, what can I do? Then we can go on that medication called loperamide or Imodium to slow down the bowel motility. Dietary things to avoid, as a same thing. Basically, I just covered that.
Another one that I just cannot wipe myself clean after a bowel movement. Stools just keep coming out, and I go through so much toilet paper, it's unreal.
Yep, that's exactly what I was talking about. It's a big problem, and I'm telling you this. Women have been telling me, what do? I don't leak stools otherwise. I don't have that problem, but every time I go to have a bowel movement, I just can't wipe myself clean. And that is because what happens sometimes, and this is many a times associated with constipation. Once that sphincter opens up, because it has to open up for the stools to come out, then it has to close down completely. But if there is constipation and the stools are not emptying completely because of the constipation, then it tends to seep out, especially if the sphincter is weak. So the interesting thing here is to address constipation. And when we give them the diary and the frequency of how often they're going, and then you realize she's not going that frequently. So then improving the constipation and then working with the pelvic floor therapist to improve the sphincter would tremendously help with this. This is not something that we would jump to Interstim or to a procedure. This is where we would do it dietarily, improve the constipation, work on the pelvic floor muscles, and then see what gives. It's a big problem.
Yeah, definitely. So is surgery for correcting the rectal sphincter complicated, and does it require time off of work?
Yeah,
and how long does it typically last?
Yeah, so that is one thing about the anal sphincter. I mean, think about this. This sphincter muscle has been tearing for over decades, slowly. And now in half an hour, you just put it together. It's almost like wearing those truss. If you're watching, this, what's that? The new serial that's on TV, Bridgerton, and how they're wearing the trusses. So it's like wearing a tight truss. And the truss is almost like how putting the sphincter together. But as I tell my patients, you don't apply ice right away and you don't live with the ice and make your ice your best friend, well, then you'll have discomfort and pain. But otherwise, it's not a complicated procedure. The only problem is if the nerve to the muscle is not functioning well, then that anal sphincter repair does not work that well. Therefore, primarily, let's say if I have a woman who comes in, she doesn't have prolapse, she has bowel leakage, then what would I do primarily? I would, once the diet and pelvic floor therapy is done, I would go with Interstim because that manages the sphincter and the reservoir working through the nerves, and it is less discomforting, less complicated, and the success is lasting. As you saw, 70% success years out. So clearly it is a successful procedure. Anal sphincteroplasty in the right patient makes sense, but per se, Interstim is superior to this sphincter repair, as studies have shown.
So speaking of Interstim, there's a few questions that had come in prior to. One is the Interstim procedure painful? I think you touched a little bit on how long it takes, but maybe to share that again, and then a little bit about the recovery and insurance.
Yeah, so it's such a quick procedure to perform, and especially I've done enough of these that literally takes me less than half an hour to get this done. It's a tiny incision in the buttocks, and we put some numbing medication properly, and at the same time, again, tell the patients apply ice. The pain is very controlled, it's very minimal. And it takes literally less than half an hour to perform. You're home within an hour. And the recovery and it's an outpatient procedure. The only reason we do, sometimes one stage can be done in the office if the stool leakage frequency is high. Then we can gauge in about 3 days what's going on. So we can just do one time in an outpatient center and it's done. Recovery, there's no such thing. You can go back to work the next day. There is no limitation. And covered by insurance, absolutely. It's an FDA approved procedure. It is clearly an authorized procedure. But then again, you have to see, based upon your formula, what is your co-insurance, what's the insurance, but it's absolutely covered by the insurance companies.
So we have a couple that came in, Dr. Kandwala. Let me take a look at them real quick and just see if there are any. But one of the things that that came in is, it says, is this called stress colon?
No, so stress colon is like when you have colitis or stress, meaning mental stress associated increased bowel activity. And that's not uncommon. And that is sometimes associated, but that's a very good question. That's sometimes associated what's called irritable bowel syndrome. And that is different, or IBS. So when there is anxiety and stress, we do see patients who come with IBS. And I did not cover it, so I'm glad that you asked. So irritable bowel syndrome is sometimes you have constipation, sometimes you have diarrhea, and sometimes it's alternating. That is something called pelvic nerve crosstalk. It's the C fibers, the pain nerves in the pelvis that's causing this to happen. Managed very differently. Yes, dietary management, pelvic floor therapy always, but then it's managed with nerve control medication such as amitriptyline. And that is a different condition. And that is many a times associated with urinary frequency, vaginal pain, pain during intercourse, and also often labeled as IBS.
Can Interstim work if someone has had part of their colon removed?
So when a part of the colon, it depends upon how much is removed and which part. Typically, the function of the colon is to absorb water. So if the colon is redundant, long colon, then it absorbs a lot of water and the stools become drier and drier. And this patient gets very constipated because it's almost like brick-like by the time it comes to the end. If, on the other hand, we have food poisoning, that the colon is going crazy, there is no chance for the colon to suck in the water because it's moving so fast. And now you're losing stools because it's totally loose and then you get diarrhea. Similarly, if part of the colon is resected and removed, depending upon which part and how much, its ability to absorb water may diminish. And if that happens, the stools will retain more water, they'll be loose, and then it'll come out loose. So when we do the Bristol score and we look at it and we say, oh, wow, this is a very loose type. So it's more near mush area. So 6, 5, 6, 7. If that's what it is, then we go back and say, okay, now let me see if I can give her something to slow down the bowel motility. And that's where we give them this motility reducing agent such as the loperamide or Imodium. Good question.
Have you ever seen where people have come in and say they've been diagnosed with IBS and you found that it was kind of just a common diagnosis or maybe a self-diagnosed, and that's not really what's been going on, and it kind of mirrors a little bit of bowel leakage? Or
yeah, it is one way or the other. Sometimes when patients have IBS, it's usually a nice pelvic floor. They are many times they're young women, who have this. The pelvic floor is great, it's proper, and these patients really need a different type of pelvic floor therapy and modulating those muscles, calming those muscles down, working with them. Many a times there's anxiety associated with it, or may not be. It's not that it's always anxiety, but it's this whole bladder pain syndrome, pelvic pain syndrome, IBS. It'll be one of the topics we'll be talking about in one of our future webinars. So I'll keep it for the next time, but it is a very common thing. It's not uncommon, but the diagnosis has to be correct. You know, we have to work with a gastroenterologist, make sure there's nothing else going on, make sure there's no allergy to some food items that's causing this to happen. Once we rule all those things out, then we will go down and say, okay, now let us focus on this IBS and then see if she would benefit from nerve control medications such as amitriptyline.
Great. So those are all the questions that came in. And before you introduce, or why don't I let you introduce your next topic, then I'll share with what we're going to do from like a follow-up standpoint here.
Excellent. So let me quickly tell you this, don't underestimate this and talk about this. The reason why we are doing these webinars, and all of us are taking time, you included, is to just increase awareness. That's my goal as a doctor at this stage of my career. I've done taking care of enough women one-on-one, but now my goal is to spread this information. That's why we're doing these webinars in female pelvic health. It doesn't matter where a woman goes for care. She can go to any doctor as long as they're aware. So please, please spread this information to whoever you know, whichever state she is in, whichever country she is in. In my case, it's a she, but it could be a he also. But awareness is key. Once a woman is aware that this condition is real and this condition is something that can be taken care of, it's not that she has to live and suffer with this. Things will change. She will want it to be taken care of. Similar to that is pelvic organ prolapse, a very common problem that we see in our practice. And it affects 1 in 10 women. Think about this, 1 in 10 women. 9.2 million, so almost 10 million women will have bothersome bulging of the vagina by 2015, something coming out of the vagina by 2015, not far away, 2050 is. Unfortunately and sadly, 30% of women will undergo a repeat procedure for prolapse, repeating it in 30%. What is it? So as you can see, this boat, which is in the middle, is a pelvic organ. It is supported by the water. So the boat stays afloat because of the pelvic muscles that are supporting it. So you need the muscles and the ligaments which are there. But as time goes by, if the water starts drying up, that means the muscle starts weakening. It puts a lot of stress on those ligaments. As you can see, the ligaments are really stretched. And then as the water dries up even more, then the boat will break off and fall. And that's when you get prolapse. And that's when you get something like this, a huge bulge coming out from the vagina. And we see this a lot of times. So bottom line, what we'll be discussing is, does a woman need her uterus to be removed to correct the prolapse? Do the newer techniques decrease that 30% risk that I talked about for repeat surgery? Does the patient need to be admitted and hospitalized, or is it an outpatient procedure? And do women have to take time off from work after prolapse surgery? So next webinar, I'm almost certain this is the date, but don't hold me to it. But it's most likely going to be Wednesday, August 24th, and I'll have Rachel follow up and make sure that you are aware of it. Well, thank you so much. Thank you for taking the time this evening and joining me to discuss one of the very, very common debilitating condition in women's pelvic health. And I look forward to talking to you about pelvic organ prolapse next month. Take care and have a good evening.
Thank you, Dr. Kandwala. As always, excellent job.
Thank you.
Thank you all for joining.